Welcome to NephroTube online nephrology lectures. In this lecture, we will cover an important topic, how to manage diabetes mellitus in chronic kidney disease patients. We will talk about some clinical tips. I will start by the target of glycated hemoglobin in chronic kidney disease patients. Actually, the target must be individualized. Some patients we will accept the target glycated hemoglobin to be less than 6.5, and some patients we will accept the glycated hemoglobin to be higher, and it must be lower than 8%. The variability of glycated hemoglobin depends on the quality of the patient itself. For example, the patients whose glycated hemoglobin is accepted to be low must be a patient with a stage 1 chronic kidney disease, early chronic kidney disease, and the patient must be fit. By fit, I mean there is no macrovascular complication, fewer comorbidities, the life expectancy is long, and hypoglycemic awareness is present, because our patients are at risk for hypoglycemia, and I will explain why now. Also, resources for the management of hypoglycemia are available. On the opposite side, if the CKD is highly progressive, for example, stage 5, or if there is multiple comorbidities or severe comorbidities with short life expectancy, so it's better to target a higher glycated hemoglobin, but it must be below than 8. So broadly speaking, we can say that the average glycated hemoglobin in our patient must be around 7. It may be lower if the patient is fit with early stages of chronic kidney disease, and it may be slightly higher in patients with late stages of chronic kidney disease and in unfit patients. Why our patients are at risk of hypoglycemia? Risk of hypoglycemia increases with chronic kidney disease progression, and the risk of hypoglycemia is more with the late stages of chronic kidney disease than the early stages of chronic kidney disease. Our patients are at risk of hypoglycemia because of 3 factors. The first factor, that with the progression of chronic kidney disease, the renal gluconeogenesis is impaired. We know that the kidney has a major role in the gluconeogenesis. So with destruction or with the fibrosis of the kidney tissue, the renal gluconeogenesis decreases, and also the clearance of insulin and oral diabetic medication will decrease, which will cause or increase the risk of hypoglycemia. The second factor that increases the risk of hypoglycemia in our patients, that with the progression of kidney disease, the patient may have anorexia and also weight loss related to uremia. So the anorexia with decreased food intake will increase the risk of hypoglycemia too. And finally, some medications carry the risk of hypoglycemia as they increased the release of insulin or whatever their mechanism. The risk of hypoglycemia increases with insulin, sulfonylurea, and the glinides, because sulfonylurea and the glinides may increase insulin secretion, and one of the most common side effects, even in patients with normal kidney function, is hypoglycemia. The same for the insulin. So in our patients, the risk of hypoglycemia is multiplied with these agents. We talked now about the target of glycated hemoglobin. What about the monitoring, the frequency of monitoring of glycated hemoglobin? Frequency of monitoring must be twice yearly, every 6 months, if the patient diabetic state is controlled and the patient is within the target of glycated hemoglobin. But if the glycemic control is out of target, or if you will change the medication of the patient for any reason, you have to increase the frequency of monitoring. You have to monitor glycated hemoglobin every 3 months, which means that you will follow it up to 4 times per year. An important clinical point, we have to put it in mind that the accuracy of glycated hemoglobin in our patients is low. The glycated hemoglobin accuracy declines with advanced CKD stages, in CKD stage 4 and 5. So actually, it is underestimating the glycated hemoglobin. So if you have patient with a stage 4 CKD and his or her glycated hemoglobin, say, is 7%, so actually it is 7.5 or 8%, because glycated hemoglobin accuracy decreases with higher stage of chronic kidney disease, and for sure its reliability is low in patients with dialysis. So for CKD patients not on dialysis, you have in the late stages of CKD, stage 4 and 5, you have to add about 0.5 to 1% on the measured glycated hemoglobin of your patient. Let's go through the treatment algorithm. What is the stepwise approach for management of diabetes in patients with chronic kidney disease? First, lifestyle therapy for all patients, physical activity, nutrition, and for sure weight loss. Then, for medications, the first line therapy for our patients who are chronic kidney disease with diabetes, the first line therapy is metformin plus SGLD2 inhibitors. And if there is no response, or if any of them is contraindicated, or if there is side effects for any of these drugs and it cannot be continued, as the additional therapy may be as the following. On top of the additional therapy is the GLP-1 receptor agonist, followed by DB4 inhibitors, insulin, sulfonylurea, and the other drugs. Let's talk about the most important drugs in this stepwise approach. Let's start by SGLD2 inhibitors. What is the mechanism of action of SGLD2 inhibitors? In case of diabetes, as there is hyperglycemia and there is increased filtration of glucose in the urine, so many of these glucose that is filtered will be reabsorbed by SGLD2 carrier with sodium. This is a co-transporter with sodium. So high reabsorption of glucose and sodium will cause decreased sodium delivery to the juxtaglomerular apparatus, and automatically, when the juxtaglomerular apparatus found low level of sodium in urine, it activates a sort of autoregulation by increasing renin and angiotensin, which will cause efferent arterial vasoconstriction, and this will increase the intraglomerular pressure with more filtration, more proteinuria, and more fibrosis. So what SGLD2 inhibitors do? SGLD2 inhibitors will block the reabsorption of glucose and for sure sodium. So increased sodium delivery to the juxtaglomerular apparatus. So this will block the feedback that was produced by the juxtaglomerular apparatus in diabetes. So there is no release of angiotensin or renin in more amount. So the efferent arteriole will not be affected, and this will maintain the intraglomerular pressure and normalize the GFR. So this is the effect, or the main effect, or the main mechanism of SGLD2 inhibitors. Okay. What is the dose modification for SGLD2 inhibitors? By the way, there is a good evidence that SGLD2 inhibitors have a cardioprotective effect. And also, there is a good evidence that SGLD2 inhibitors have a renoprotective effect in both diabetic and non-diabetic chronic kidney disease patients. As you know, that was approved by the DAPA-CKD trial. Regarding their dose modification, actually, most of them or all of them are contraindicated to start if GFR is below than 30. So don't start SGLD2 inhibitors if the GFR is below than 30. Regarding canagliflozin, if the GFR is between 45 and 60, there is a dose modification. The maximum dose will be 100 milligrams once daily. Regarding the others, there is no dose modification once the GFR is more than 30. But if it is below than 30, avoid initiation. Don't initiate. Okay. But if you initiated any of the SGLD2 inhibitors, say you initiated dapagliflozin for a patient with GFR 45, when to stop the SGLD2 inhibitor? As it was mentioned by the KDIGO guidelines, once SGLD2 is initiated, it is reasonable to continue this even if the GFR falls below 30. So don't start SGLD2 inhibitors if the GFR is below than 30, but if the patient is already on SGLD2 inhibitors and his GFR declined below 30, don't stop the SGLD2 inhibitor unless if it is not tolerated by the patient, there is side effects, or if the patient started dialysis or received the transplantation. What are the side effects of SGLD2 inhibitors? Hypoglycemia, but this is usually if SGLD2 inhibitor is mixed with other medications that cause hypoglycemia, such as insulin. And for sure, genital infection, mycotic genital infection, and for sure, dehydration. And this is very common if the SGLD2 inhibitors is combined with diuretics. This may increase the risk of acute kidney injury. If it is combined with ACE inhibitors and with diuretics, it may cause euglycemic ketoacidosis. There was a history for amputation with canagliflozin, but later more meta-analysis and systematic reviews and studies approved that canagliflozin is not causing amputation, and there is also little evidence that they may cause fractures. This is regarding SGLD2 inhibitor. What about metformin? Regarding metformin, when to start or what is the dose? Again, if the GFR below than 30, don't start or continue metformin. Okay, if it is below than 30. Okay, if it is between 30 and 45 GFR, you have to give 50% of the maximum dose of metformin, which is about 1 gram. If the GFR between 45 and more than 60, we can say if the GFR is more than 45, you can give the full dose of metformin. You will start by a small dose, say 500 milligram or 850 milligram, and you can titrate the dose up every 7 days till reaching maximum dose. One of the most important side effects of metformin that is always missed, that in metformin interferes with vitamin B12 absorption. So it is important to monitor vitamin B12 regularly if metformin is given for more than 4 years. So if the patient is on metformin more than 4 years, you have to monitor the level of vitamin B12 annually, or if the patient is at risk of vitamin B12 deficiency. Once the GFR is below than 30, you have to stop metformin totally. So below than 30, we don't continue metformin and we don't initiate metformin. This is different, or this differ from SGLD2 inhibitor. SGLD2 inhibitor below 30, we don't initiate SGLD2 inhibitor, but we can continue SGLD2 inhibitor if the patient has started SGLD2 inhibitor when he was when he had a higher GFR. Finally, what is the most common side effects of metformin? For sure, it is the gastrointestinal. This is very common, particularly with the immediate release formulation. That's why if the patient is on immediate release formulation and has gastrointestinal side effects, you can convert him to extended release form. When to stop metformin away from the GFR, you have to stop metformin for any patient at risk of acidosis or dehydration. If the patient has a history of liver disease, alcoholism, liver failure, if the patient will take contrast, whatever the shape or the technique of the contrast, and if the patient is in sepsis, if the patient is in dehydration, all of these situations you have to stop metformin. The second line of treatment that I will talk about, I will mix my talk about the GLP-1 receptor agonist and DB4 inhibitor, because their mechanism of action is nearly the same. It is not exactly the same, but they are working on the same axis. Normally in our body, we have the gastroinhibitory peptide, GIP, and the GLP-1. Normally in our body, they have a benefit effect, multiple benefit effects. For example, they increase glucose utilization, decrease fasting lipolysis, and many actions on multiple organs, and we get a good benefit from them. Their benefit is to maintain the normal level of blood glucose and other extra benefits away from the glucose control. But actually, they called incretins, by the way, the GLP-1 and the GIP called incretin, but actually they are metabolized by an enzyme in our body and they become inactivated. So we have two drugs. The first one is DB4 inhibitor. The DB4 inhibitor inhibits the enzyme that cause inactivation of GLP-1 and GIP. So this will elevate the level of incretins in our body, and we take the benefit from their pharmacological effect. Also, we can give incretin mimetics. They are GLP-1 receptor agonists that are resistant to the natural enzyme present in our body. They are not easily inactivated, and this also will cause increased level of incretins in our body. That's why it is recommended not to use a DB4 inhibitor and incretin mimetic drug at the same time, because both of them is working on the same axis, which is increasing the level of incretins, whatever the way of each one of them is different. Regarding GLP-1 receptor antagonist, how to use or what are the precautions? Actually, they have a very, there is a high evidence that they have cardiovascular effect, major cardiovascular effect. They can help in lowering the blood pressure. They can cause weight control, but the most common side effects of them is gastrointestinal side effect. And as I mentioned, don't combine them with DB4 inhibitor. And also, if the patient is at risk of medullary thyroid tumor, you have to avoid this drug because there is theoretical or experimental evidence that they may cause medullary thyroid tumors. And also, there is an experimental evidence that they cause acute pancreatitis. So it is better to avoid them in patients with history of acute pancreatitis. As I said, which glucose-lowering drug has a cardiovascular effect? The metformin may be GLP-1 receptor agonist and SGLD2. But regarding the DB4 inhibitor, no specific effect on cardiovascular risk, and also their effect to decrease progression of GFR or improve the renal function is not that solid or strong. That's why they are not on the top of the list in our stepwise approach. Regarding the dose modification of DB4 inhibitors, you can look at this table, but I will mention that linagliptin is the only DB4 inhibitor that doesn't need dose modification, and also it is the only non-dialyzable DB4 inhibitor. All the DB4 inhibitors are dialyzable, but some by different degrees, but the only non-dialyzable DB4 inhibitor is linagliptin. Finally, I will mention the dose modification of sulfonylurea, but as mentioned that sulfonylurea carries the risk of hypoglycemia in our patients, especially with the progression of chronic kidney disease. So it is better to avoid them as much as possible. Actually, the glyburide, you have to avoid its use if the patient is stage 3 to 5. Glycolysis, it's better to avoid if GFR below 40. Glimepiride, as it is mentioned, if the patient with stages 3 to 5 start at 1 milligram daily and close monitor patient, but it must be avoided also if the GFR is below than 30. Glipizide, no dose adjustment, but also in these stages, you have to monitor the patient because the risk of hypoglycemia is present. So actually, there is no drug that you can use safely from this list. Sulfonylurea carries the risk. Sulfonylureas carry the risk of hypoglycemia in our patient, so it is better to avoid them. And finally, the last slide, one of the most important factors that affect the success of the management of our patient is the self-education. Self-management education, the patient must be educated about his condition, about his medications, about his complications. This will increase engagement with medication and glucose monitoring. This will decrease the risk of hypoglycemia and other complications. This will improve self-management and self-motivation and improve diabetes-related knowledge, improve vascular risk factors, improves emotional, mental well-being, satisfaction of the patient, and his quality of life. I hope that you like this lecture. I tried to cover the most important clinical points in the management of diabetes. Thank you, and see you again in next lecture.